Okay, let's get started. I'm Larry Boris, the Executive Director of the National Association of Worksite Health Centers. I want to thank everyone who's taken time out of their day to participate in this program. We know that Worksite Health Centers have lots of opportunities for data and data collection, but one of the key things that many still don't take advantage of is claims data. And really understanding their populations and the history and the conditions that they have, where the costs are, and who's involved and who's getting what kinds of services. If you don't have the data available, if you don't take advantage of it and you don't analyze it, you really are losing great opportunity to be as more impactful as you can with a worksite center. So today's program is all about the importance of claim data. And we've got two presenters, and I'm going to ask them to introduce themselves as they go, and then we'll get started. So Scott, why don't you start out? Introduce yourself, please.
Great, thank you. I'm a family practitioner. I have been in practice now for 35 years and really I'm sitting in an on-site, near-site clinic right now for an energy company that I run and work in, obviously, occasionally. And I am a passionate about advanced prepaid primary care, which is what we're doing in Worksite Health Centers, and the need to integrate the data. So today, it's my pleasure to share one example of how data can be integrated into the workflow that empowers everybody from the receptionist to the physician to being a fantastic asset to team-based care.
Great, thank you. And Jed Constance, introduce yourself, please.
Sure. I describe myself as a fiercely independent consultant focused solely on primary care, finance, and delivery, and frankly, in that order. And what I really have really come to appreciate, is the opportunity that on-site worksite health centers have in really being able to meet the needs of the covered individuals that they are given the opportunity to care for. And Scott and I have collaborated on a number of projects and conversations for sure. So while Scott will provide the clinical perspective, how a clinician actually benefits from this information and uses this information, I'm going to handle some of the more mundane stuff in order to stimulate conversation. To Larry's point, this really needs to be viewed as more of a conversation. And speaking for myself, and actually speaking for my co-presenter who can't make it today, because he's been called away to hospital business, Kevin Milligan from Cleveland Clinic Union Hospital has offered anyone who might have a question relating to the way they are benefiting from the integration of claims data. He's more than happy to offer insight, including painful levels of detail as to how they arrived at the process that they are currently using. And so that's really where I'm coming from. I'm coming from the standpoint that it's all about data in the hands of the right people in order to make the right decisions on behalf of the covered individuals. So, Larry, to your, and I have the opportunity to serve on Larry's board, and I'm honored to be in that position and feel that now it represents, frankly, the best possible business case for high-performing primary care, advanced primary care, enhanced primary care that is aimed at populations through these worksite relationships. How's that, Larry?
That's fine. That's fine. And I do want to let everybody know this session is being recorded, and a link to the recording and slides will be available to you afterwards, as well as any of your colleagues that would like to take advantage of it. So with that, I'll turn it over to Scott and Jed for our presentation. And when they're done in the foremost part, we're going to do our typical roundtable where I will be calling on each of the participants and attendees for any questions or comments relating to the topic or the presentation. So be prepared for that. If you have something that comes up during the talk, please put it in the Q&A section, and we'll address it at that time. So back to you, Jed and Scott. Thank you.
Thank you. That's So really what we wanted to do was offer this overview of how primary care services And the impact of those services are evaluated by purchasers. And again, the best available information is claims data often, not always, but often. And so we're going to speak to and talk about the value of practice level encounter data and really, explore possibly some strategies that can be adopted in order for this to come together this way. And so I'm going to be speaking on behalf of Kevin. I have obviously been working with the folks at Union Physician Services, which is part of the Cleveland Clinic Union Hospital, for almost 7 years now, and they have gone through some nice evolution in terms of perfecting this process of making sure that there is a 360 look at what's happening to and for the patients they care for. But for me personally, actually, I cut my teeth back in 2008, 2009, when I was working for a small community hospital in upstate New York. And our single largest employer, Cornell University, after accusing us as a physician hospital organization of being money grubbing sons of guns, I said, well, if you really don't like the way things are working, maybe we can sit down, convene this conversation between yourself as the employer. I didn't use the word purchaser back then. I probably should have. And us as the so-called delivery system, physician hospital organization delivery system, known as Cayuga Health Partners. Make a long story short, we had the opportunity to develop an enhanced primary care program called the Cornell Program for Healthy Living. And they continue to offer that long after I went away, which is fine. But the strength of it is the primary care community that stepped forward and chose to be more collaborative than combative. And family medicine associates, I like to point to them as the single best example of innovation at the primary care level, at the practice level, in some very basic ways. They didn't overthink it. They simply said, what can we do to ensure that these covered individuals who have an enhanced benefit for primary care services got the best possible experience, and we were able to provide Cornell and their claims administrator, who was Aetna, continues to be Aetna, had the most robust information possible in order to really understand what we were doing to support these covered individuals, to support these folks. And so they, tweaked the benefit plan so that it drew attention to the program and created a heightened sense of value for folks to opt in. All the programs and projects that I've ever been involved in have always included opt-in models where folks vote with their feet and clinicians agree to be part of this. No one is dragged into something. They're all invited in, if you will, and then over time, the level of interest grows and folks become more involved in it. But the PHO purchaser model, which again dates back to 2008, 2009, is, in my opinion, the best example of a simple, straightforward approach that draws attention to primary care, but also ensures that they approach this in the simplest possible way of capturing information, capturing encounter information. Now, this old program back in the day was based on enhanced fee-for-service, but for you correct coding folks out there, what we were able to negotiate at the time in order to facilitate this revenue model was that any claims submitted for these services to Aetna would be paid, period. There was no claim edit, no claim audit, no primary care was exempt from any sort of minutia management, micromanagement, because back in 2008, 2009, we were not astute enough to be able to calculate a payment in advance of care. Fast forward to what I had the opportunity to work on in terms of Cleveland Clinic Union Hospital. And it was before they were acquired by the clinic, back when it was just Union Hospital, small community hospital, was this enhanced primary care program built on the direct primary care model. We didn't call it the direct primary care model per se, because most folks didn't know what that meant, but they did know what an enhanced primary care program could represent. And in this instance, Union Hospital stepped forward and said, we'll be the first employer into the program. We'll be the first employer in the, as we design it, as we build it, we're going to give our covered individuals an opportunity to benefit from it. And so, I mean, Union Hospital was self-funded. Union Hospital had unfettered access to its own data, often didn't know what to do with it, but they nevertheless had access to it. And so they directed their claims administrator to accept $0 claims, because what Union was able to do was carefully calculate the future value of primary care. And what this illustration represents is they packed the payment in advance of care made payable to primary care full of a pretty broad a bunch of stuff and services, including some laboratory services, so that at the end of the day, as a hospital, they were actually able to buy lab services from themselves for less than what you would otherwise buy it from LabCorp for. But their agreement with themselves was, if we're going to prepay for all these services for our covered individuals, in order to set the stage and show our community how we can re-engineer payment, adopt true payment reform without any strings, without any restrictions, we need to be able to lead by example and be as comprehensive in nature in terms of what goes into the prepayment amount. But what they were doing was painting a picture that they could show other employers in their market, which they've done successfully. But regardless, they were able to show that if you can carefully anticipate what the covered individuals would need, then you can calculate that as the future value of primary care. And then, not surprisingly, what have we seen? Well, we've seen that what they refer to as the DPC, which is the Enhanced Primary Care Program, and the non-DPC, which is everybody else, the non-DPC community continues to have rates of utilization that are measurably higher than the DPC program, than those that are enrolled in the primary care program. And the reason they know this is because they were successful in creating a workflow that involved $0 claims. So the primary care community, the Union Physician Services primary care community, continues to submit claims just like they did before. But in this instance, instead of it being the customary fee, it dropped to $0. And the claims administrator agreed, and they understood that they needed to do this in order to retain the business from Union Hospital at the time. Because, you know, concurrently what Union had done is they had considered some alternative proposals from other claims administrators who already were able to commit to a $0 claim process. So, you know, so they were able to stay with their incumbent claims administrator. But that being said, there is a monthly export of claims data, which includes both this encounter information as well as the fee-for-service information that happens outside of the prepayment amount, so that we are able to calculate, they are able to carefully calculate the net dollar difference between for total cost of care on a per patient per month basis for those that are in the program and those who are not. And so then their human resource department, interestingly enough, has toyed with benefit plan changes that are designed to first draw attention to the enhanced primary care program, and then subsequently reward covered individuals who vote with their feet and opt in to the enhanced primary care program. I mean, their primary care community is part of the open enrollment process every year, and they are armed with data about the population so that they're not just talking about some philosophical program. They are actually able to do some meaningful healthcare reconciliation with folks based upon the agreement that they have with the primary care community to serve in an expanded role as sort of a care management advisor, case management advisor, wellness program advisor, and the like. So it is something that can look differently, but in both instances, whether it's the PHO purchaser model or the hospitalist purchaser model, the whole thing is driven by an agreement up front that encounter data will be robust and encounter data will be timely in order to really help both sides of the conversation understand the real dollar impact of the results. So when we continue to have this conversation, we need to really have a strong enough purchaser perspective from that standpoint, because they just simply want to know, where's the money going? And if there's no data going back and forth between those who provide care and those who pay for care, it's very difficult to be able to answer that fundamental question. Because then that drives folks to wonder, where's the opportunity to spend less money? And part of what we think is important, or what I think is important, and many of us who support the idea of primary care, is where's the opportunity to spend less really is a conversation for the clinician, more so than it might be for those who come up with a variety of strategies. You can do all these things in terms of narrow networks and some direct contracting to get less than retail. You know, in a previous life, that's what I used to do for a little company called Blue Cross Blue Shield. I would get folks to accept less than retail for no apparent reason, recognizing that folks, bless their hearts, and I mean that in a good way, they're going to figure out how to make up on tomatoes what they lose on potatoes. So it really is not, it might provide some short-term bumps in the financial picture, but it may not necessarily be the kind of long-term play that most folks are looking for. And the prepay review, where you slow down claim processing in order to take a look at stuff in advance, or the post-pay review, where you simply figure out you need to take money back from somebody. So those are largely administrative, but not necessarily long-term strategies, because after all, we're all subject to physics. Every action, there's an equal and opposite reaction. So from a purchaser perspective, you know, they want to know where the money's going. They want to know what the opportunity is. But I think the data piece really helps everyone come together in terms of being on the same page, in terms of really what the opportunity is. So transparency is the key, and I think is critical to this whole conversation. What's happening inside primary care? What this illustration represents is some work I did on behalf of the Texas Academy of Family Physicians, where we did some research around, in an optimal world, if you were to create and calculate this payment in advance of care for primary care, what would the dollar distribution look like? And in this scenario, what we're seeing is that a lot of the services that have been happening external to primary care should happen internal to primary care, should be part of primary care, should be channeled through primary care. And but in order for that to be both understood and managed, there needs to be some transparency inside primary care, so that there is an opportunity, if someone's going to get paid in advance for some acute care, what sort of acute care is happening? If someone's going to get paid in advance for preventive care, what sort of preventive care is happening? Likewise, for wellness services, disease management services, and care management, care coordination services, what does that look like? And so there is an interest in and a desire for that level of transparency in terms of what does the encounter data seem to suggest, because after all, the question that primary care has to answer, that the clinician has to answer, is what's the best mix? In other words, this is representative of a population in terms of the distributed dollars. Some folks inside that population are going to rely more heavily on care management, care coordination support. Others will need more disease management support. Others will need more wellness, preventive services. And others will need some acute care, but not everyone will need care at the same rate and the same level because their needs are different. And so part of the transparency is to understand what are you doing with and for folks, and in what sort of distribution. So taking a breath. What should happen, nothing has to happen, but what should happen is this idea of adopting the simplest non-revenue cycle management approach to encounter reporting. This should not be done in a way that is aimed, despite what we did with the Cornell program for healthy living, this should not be done in a way that supports revenue cycle management. This should be done in a way that supports data capture, because the prepayment model eliminates the need for revenue cycle management activities. And when we rolled this out at Union Hospital, and Kevin Milligan would echo this, there were folks inside the hospital who just were freaking out. We can't do it this way. We can't report $0 claims. We'll screw up our Medicare something or other. Well, the simple truth is you won't, because the business agreement exempts those transactions and that activity, for example, from Medicare reporting. So $0 claims have no bearing on Medicare because it is a different business model supported by business agreements. So you want the simplest approach. Then you want to make sure that you're feeding the existing systems to minimize parallel systems, if you will. But that being said, in cases where you can't feed the existing system of data collection, then you need to come up with some innovation, such as creating monthly export files, either an Excel file or a CSV, from whatever source that you have, to be able, such as a electronic medical record or a practice management system export, so that ultimately on a monthly basis, you have this opportunity to commingle data that helps to drive the conversation around both total cost of care as well as the services that are being provided, so that you can do that comparison. But I can't stress enough the need to really take a step back and adopt the simplest non-revenue cycle management approach for encounter reporting. And then don't be shy. Put away your National Correct Coding Institute National Correct Coding Institute material and information, which we did at Union. Create custom codes as necessary. As long as they are 5 characters, they can fit inside the system. We're not talking about codes that are payable because we're dealing in a prepayment model. We're talking about custom codes that allow for this easy insight in terms of what's happening to and for folks. And so in the case of Union, and frankly, in the case of the Cornell program for healthy living, we created 5-digit codes that reflected a level of service for disease management support, for care coordination support, and for wellness services. In the instance of the Cornell program for healthy living, we went into more painful levels of detail around the wellness services, so that the care team could report out instances where they're supporting the covered individual in terms of stress, diet, exercise, and sleep. And so, because that was a program that Cornell was particularly interested in as part of their whole effort. So, be creative, negotiate with your client, or if you're the client, negotiate with your source of primary care around a reporting model that is simple and non-revenue cycle management based, but nevertheless doesn't shortchange you in terms of the kind of insight and information that you subsequently have an opportunity to take a look at. And then finally, in the case of everything that I've ever been involved in, you want to be prepared to evolve this. This is not a set it and forget it kind of arrangement, because you're going to learn. You want to map out your process and make sure everybody's on the same page in terms of what it means. You want to learn from the process. You want to learn from what the data is suggesting. You want to focus on the documented needs of the covered individual. You really want to hone in on making sure that you are measuring what matters as opposed to simply measuring what you can. And obviously, because it's the purchaser's money, you want to make sure you're focused on the purchaser goals and their expectations. What do they want to see different next year than what they're looking at this year? So what to collect, how often to collect, and then ultimately map it to some kind of value-based reporting, whatever you think is important. So then this is my gentle transition into my good friend, Scott, who is going to talk about the analytics, but it's an opportunity to better understand the population, target the population, align the care and services. Fair is not equal in this conversation for sure. Measuring those results and acting on those results. So from a clinician's perspective, there is, and this is what you're looking at in terms of the risk score analysis is real information from Union in terms of the way it distributes. And I'm going to let Scott get into this in terms of how he has arrived at looking at this from a risk score perspective to support the needs of the clinician. So I look forward to any questions that are coming up a little bit later on. But Scott, if you want to go ahead and start, I'll advance this for you. And I'll drop into mute.
All right. Well, I'd like to just make a couple of quick introductory remarks to what we're doing. And that is, it's an honor to be able to do the data analytics for the Cleveland Clinic Union Hospital and be able to share that with them. And by way of my background, I was a chief medical and strategy officer for 510 doctors. And so what you're seeing here, there are many scars on my back from the doctors' tongues in terms of getting them so that they felt really comfortable with the data and that it worked for them. But I hope that you'll see at the end of this how you can take your claims data, which primarily consists of medical claims, pharmacy claims, and the eligibility information, although sometimes it's participation, sometimes it's biometrics and things, and you can leverage that to facilitate the advanced primary care that your on-site, near-site clinic or worksite wellness center might be a better way to say that, can function. And so that's really been my, passion for the last 15 years is how do we take all this information that you all as employers have that the clinicians would benefit from and marry those. And we have done this successfully now many times, and including a large Medicaid Medicare group up in Jamaica that we have the privilege of working on, as well as the Cleveland Clinic in Ohio. And here, and then also with some on-site, near-site facilities. So when you take data and you really get into a clinical mindset, like you want to practice medicine, put yourself in this situation, you want to do the best possible thing as efficiently as possible. We know that right now there's another study published 2 months ago that showed if primary care doctors by themselves tried to do all the protocols on our patients that we needed to during a day, we would be working 23 hours a day, which is ridiculous. So the only key or the only way to go forward is through the team-based care. And that's what we've got to develop. So the data analytics that we have created, and by the way, in the large group up in New York, I talked about, we integrate Epic data with our clinical data and give it back to the actual clinicians in Epic. So they actually have what I'm about to show you in Epic to integrate with the clinical care, and it's a two-way data flow. So took a minute, but it actually was very able to be done and has been very useful because what I'm about to show you, you'll see how you get the telephone, the person who answers the telephone, the receptionist, the medical assistant, the nurse practitioner, the physician, the office practice manager, and navigator all on the same page very quickly. And it creates this team-based approach that really moves things off of the clinician, the doctor, nurse practitioner, and onto the other members of the team, so that a much more robust offering can be provided. So let's just go through the 5 questions that we answer. First of all, what risk can't be controlled? Like, what is walking in the room? As a doctor, walk in the room and see a patient, what am I walking into? There's a tremendous data trove, if you will, in your claims that the clinicians in the practice don't have access to. They don't know what all the specialists did. They don't know about that emergency room visit or urgent care visit that occurred a couple of weeks ago. And the patient doesn't think to call the doctors. Oh, by the way, I went to the emergency room a couple of weeks ago, and this is what they diagnosed me with. So there's all this rich data that the clinicians that are the primary care clinicians don't know that you have access to and you can share. But oftentimes we can't control that. And I'll go into that a little more in a minute. What did the providers drive? What can a clinician, would be a better word, do to help a person? There's a lot. But the third thing is, how is the individual working with that clinician is equally important. When I went in to see a doctor and I said, hey, here's the kind of quality metrics on your practice, which was very offensive to many of them. And they'd say, well, I don't chase gaps in care. I take care of people, and they are right. But the first thing out of their mouth was, my people are sicker. That's why we have the absolute risk score that I'm going to share with you. And then the other thing they'd say is, but my patients won't do what I ask them to do. And they were right. Oftentimes they could give the best advice in the world and it wouldn't work. So that's the third aspect of the risk assessment that Converging Health does. The next thing is, what are the most important things to get done? Because it's not uncommon to have 28 or 30 things that would help a person lower their health risk, reduce the chance of heart attack, stroke, cancer, musculoskeletal issues, et cetera. But obviously, it's hard for someone to do 20 things. So we prioritize those with AI. And then again, what order should they be addressed in? So that said, go to the next slide, if you would, please. And let's look at time. Yep. I'm going to go pretty quick. So we developed what we call the whole person risk score. There are 3 aspects of it. The first is absolute risk. I'm not going to change a person's age, probably not going to change their gender, socioeconomic status, social determinants, the conditions that they have. Usually they have those conditions, particularly chronic care. It's great to reverse diabetes, but it's not common. What medications they're on, how many medications they're on, how many doctors they're seeing, all of that is kind of what I'm being handed as a doctor or a care team, more accurately, to take care of. The second aspect is, how am I doing, saying, okay, here's what's important. Here's what we need to do. Here are the areas where we can decrease your risk of having something bad happen to you in the future. Here's what your numbers are. Let's get those to goal. And so there's a lot I can do as a clinician, but if that person won't play the game with me, then it's very hard. So we have what we call the FLAIR, or the risk score, which looks at, are people staying on the yellow brick road, right? The 2 ditches are not enough care, too much care. Are they getting the right care? And are they leaning into seeing the people they need to see, getting their prescriptions filled, working with primary care rather than just go to the emergency room every time they're sick, those kind of things. So you put all this together and you get a great 3-dimensional, if you will, picture of that individual you're caring for, how to communicate with them, where they might have health literacy deficiencies that you can help clean up to get them to engage more effectively, and just really empathy for what they are having to overcome and work their way through from an absolute risk standpoint. Next slide, please. So let me give you just a quick taste of this. So low risk people on the absolute risk are healthy, straightforward people. Primary care can give them everything they need. And it's really focused on immunizations, lifestyle, which is primary prevention, and pre-cancer or identifying cancer very early, which is secondary cancer or prevention, excuse me. Then we get people who have multiple conditions. They may have 1 to 3 providers. They really need somebody to help kind of corral them and keep them on the yellow brick road. And tertiary prevention, which is the prevention of complications of chronic conditions, becomes very important. And finally, in absolute risk, you have people that are out there, they're just sick. They have multiple providers, multiple medications, complex care, and they need kind of an intensive outpatient care system to make sure that they get the care that they need. Clinical quality, you have people who are getting everything done. They're checking the boxes. Their gaps and cares are closed. Usually these folks are pretty straightforward to take care of. You have people who have multiple conditions that have many gaps in care, and it takes like a complex or more assertive, proactive education as well as intervention. And then finally, you have people who just aren't getting the appropriate care. And unfortunately, we have this divorce in the American healthcare system. What patients and corporations want is great care at a fair price. What the system's being paid for is more care, regardless of the quality, regardless of the appropriateness. It's just more is going to get you paid more. So we've got this schism between what people want to pay for and what the system pays for. And as a result, you get a lot of very inappropriate, very crazy kind of things going on in the marketplace. Then in terms of the flares or the system utilization, you get people who are, they may have rheumatoid arthritis and they may have hypertension, diabetes, and obesity, but they're getting everything that they need. They've got a great relationship with their primary care and specialists. And so their risk and their appropriateness of care is very high. Then you get people who getting inconsistent care. They may not be getting their prescriptions filled regularly. They often end up going to multiple different specialists who aren't coordinating care, ERs, urgent care, and so forth. And then you've got people, of course, that just go to the emergency room when they have a cold, or they go to the emergency room for a real reason, but then they get to a sensitive specialist who sends them to another specialist, who sends them to another specialist. We used to call this a mafia. When I was managing the 510 docs, they'd get caught in the mafia, and by the time we found out about it, the primary care doctors, they'd already seen 5 specialists and they'd gotten a lot of inappropriate care. But when you don't have access to claims data, that happens all the time. So this is where, as an employer, you can really help people by getting them access to the claims data. So at the end of all this, you put it together, there's a number and a total risk score. And this is what's so important to make available, if you will, to the care team. Next slide. Is because what they can do at that moment is they can look at the absolute risk score. Go ahead and just hit it 3 times. Absolute risk score, the gap risk score, if you will, or the clinical risk score, and the flare risk score. And now a receptionist in Queens, New York, will get a phone call. They'll pick up the phone. If that person's risk score is 100 or 120 or 200, they say, I just don't feel right. I'm a little jittery. My stomach's not normal, then they'll say, let's get you in today, because there's a high probability that person ends up in the emergency room. And this could be anything from a heart attack to, as in medical school, anything from the chin to the belly button's a heart attack until proven otherwise, right? It could be anything from a heart attack to, them just, having an overdose of their 15 medications. And so it's having them feel odd, but they're going to end up in the emergency room if you don't get them in. Whereas if the person has a risk score of 10, there's a very low probability they're going to end up having something terrible happen. So doing a telemedicine visit or getting the RN at the clinic on the phone with them immediately to just handle the problem offers a tremendous opportunity to decrease the time for care and to get them taken care of, regardless of which side they're on, if you will, of the risk continuum. Next slide. So here's what it looks like graphed out, a simple 2x2. You see the whole person risk score across the bottom and how much they have entered, how much money they've spent the last 12 months. And each dot here is a person. So you end up with 4 groups, right? You end up with people who are healthy and you want to keep them healthy. They're in what we call the left lower quadrant. And this is 50 to 55% of all your people. Jed, go ahead and hit the button, please. Yeah, there we go. And they need, physicals or, regular relationship building exercises, if you will, with their primary care, screening, immunizations, 50 to 55% of your folks. Then you have people who become pregnant, gallbladder, appendectomy. They're healthy people. Maybe they break a leg, skiing backwards, whatever. You get the idea. And they will flip up and come down. I'll go over that in a minute. but there's only about 1 to 2% of people. It's very hard to guess which of the 50 to 55% land there. But here's the real quadrant you want to pay attention to. These are people who have not yet had that terrible thing happen to them. It's 30 to 35% of members. It's not much of the spend, but if you can get people engaged here, you will save a fortune, because if you don't get them engaged, they're going to go to what we call the right upper quadrant, which are the 8% spending 80% of your money. And 70% of the time, they didn't have to be here if the advanced prepaid primary care had engaged them well. So to say that again, and Jed, keep up with me on the buttons, the left lower quadrant, you want to support, but you don't want to have them fill your clinic system. And so you keep them engaged and make sure they know where to go if they have a problem, but you don't have them block your clinic up. The upper quadrants, those are specialists, those are imaging centers, those are facilities that you want to have care coordination, case management, but that's often overwhelms or too much for the primary care office, particularly if they don't have access to claims data. And then the right lower quadrant is the money quadrant. That's where you can make a huge difference. And that's where the worksite wellness centers are worth more than gold. Next slide. So the goal here then, go ahead and hit the first button, is to on the lower quadrant, you'll actually see their costs go up slightly as they get their medications filled more consistently, they get their preventive screenings, they get their primary care. Usually that ends up going up $100 or $150, maybe $200. On the upper quadrants, they're going to regress down as just a product of the fact that people do get well, die, go on disability, or leave the company, so they'll drop down. And then we want to move everybody to the left to lower risk, which this particular formula quantitates. Next slide. The other thing I just want to make a quick point on is that people in the left lower quadrant will pop up to the upper quadrants, but within 9 to 12 months, the vast majority of the time are back down. The people in the right lower quadrant, the right upper quadrant, 60% of them leave every year. Let me just say it again. People that are high cost, high risk, 60% of them leave that quadrant every year, and a new 60% pops up. Well, the sad thing is when you look at the people who end up in the right upper quadrant, if they had gotten advanced prepaid primary care that worked, 70% of the time, they would not have gone there. So if you really want to get ahead of healthcare's benefits spend cost, it's by getting the people in the right lower quadrant into advanced prepaid primary care and getting them engaged in their own health and well-being. Working on the upper quadrants, I hear everybody talk about it all the time. Oh, we want to work on the people that are expensive. You're getting there late, a day late and $1 short. Working on that right lower quadrant, that's the secret. Next slide. So here's just a depiction of this. Final slide, I think, maybe one more after this. But the people in the upper quadrants, you can see are spending $100,000, $200,000, $300,000. The people in the bottom quadrants are $2,000 to $6,000. But if you look at their risk, their clinical risk, it's identical. It's identical. These are all people who have a risk of score of 34 or higher. The only difference between the bottom and the top is the people on the bottom haven't popped into the top yet. But if you don't get proactive with them, they will. And you get to write the check 70% of the time for people who didn't need to be there. Next slide. Okay. So again, just to wrap it up, making data actionable, giving clinicians access to claims data is powerful. It lets them know what they can and can't do, how that person's participating in care, and help them prioritize what needs to be done. All right, so that's it for me. Let's go on to the questions and comments. I hope that wasn't too verbose or long-winded.
No, that was great, Scott and Jed. Thank you very much. So what we're going to do is we're going to go around the table and ask people if they have comments or questions. I would just start out with one that I've heard from a number of the Worksite Center vendor partners, that some of the health plans make it difficult to submit $0 claims. Can you talk a little bit about that, or your experience, or how to overcome that?
Well, and I mentioned it briefly in my comments when I observed that the folks at Union Hospital had sought proposals from competing TPAs because they really wanted to demonstrate to the incumbent TPA that they were serious about doing these things and innovating in this form and fashion. So if you do end up with a claims administrator that is resistant for a variety of reasons, and sometimes it's because from an information technology standpoint, they're just not that good. They're not that capable. It would otherwise corrupt their system, if you will, or something along those lines. Then really what you're talking about is ultimately what would be of value is a data aggregation strategy where once again you work out a monthly gathering of encounter information from the source of primary care, and then aggregate the data outside of the claims administrator. You extract all the data from the claims administrator and put it together. Believe me, I did time with a couple of claims administrators, a Blues Plan and an independent TPA. So I know what it means to be wholly inadequate in terms of being able to support the informatic needs of the client, of the purchaser. But it really is, it's important for the source of primary care, the on-site, near-site health center, to be able to articulate to their customer why it's important to aggregate data, and frankly, why it's helpful for the purchaser to delegate to the on-site, near-site vendor the opportunity or the responsibility of working out the data aggregation piece. You want to take that off of the purchaser's plate and assume some level of responsibility for it as a source of primary care, because then that puts you in the driver's seat.
Yeah, Larry, I would be a little bit more succinct to my answer. I believe in the golden rule. He who has the gold rules, and for the corporations that are on, they just need to tell their. I think CAA has changed the landscape on this. Insurance companies don't have the right to keep your data. It's literally now been mandated by the federal government that they have to turn over the data. They cannot keep it, and so I would just say to them, you need to give us our data, number one. Number two, we're going to have zero claims sent through as a regular claim, and we want that included. And it's a golden rule, and I think that when companies abdicate their power, they get the answer no. But I think with a little bit of particularly getting the broker involved and saying you just need to get this done, and I don't want to hear no, just come back when you have a yes, and it needs to be quickly, I think is the right answer to that question.
All right, thanks very much. Well, let me start out, ask Kim Tolson. Kim, do you have any comments or questions about the discussion?
Hi, Larry. Thank you. This has been really helpful. We actually, over the last couple of weeks, have been in communication with a broker that represents 4 of our on-site clinics in the upstate of South Carolina. And one of them has been pushing for exactly this. So it was refreshing for me to hear, and I have a couple of team members on as well, that basically the employer needs to just push for the information. That's the piece that we've been missing, is that connection between the two. So this has been really helpful, and the quadrants that you put the information in, I think is going to be well received from our group. So I appreciate tremendously you having this, and we may need to reach out if we meet some resistance and see if we can get some pointers from a couple of you that have managed to get this data. So thank you so much.
Well, that's really, really wonderful to hear, Kimberly. Thank you for sharing. And, so often when Jed and I go and talk to people, they're like, oh, you can't do that. That's not possible. It's not done. And we're like, okay, actually it is. And it's being done in Medicare, Medicaid. It's being done on site, the Worksite wellness centers, health centers, and it's being done in private practice. So please don't take no for an answer. And it's leadership like that from people like you that's going to change the marketplace.
Well, that's great. Yes, because in the past we have been told no. So we are going to go after it again. Thank you.
Thank you. Don Carey, Don, any comments or questions? Don?
You're still
Take
muted.
yourself off mute. Yeah. Okay. Allie Hartman, any comments or questions?
Yep. Can y'all hear me?
Yes, we
Yeah,
can.
go ahead.
Yeah, I first of all, just awesome. Lots of great information. I'm curious. I'm was loving the quadrant slide, and I'm just curious what you all see as the strategies that work to help target that lower right hand quadrant. Like, what are employers doing that reach those people? Because I feel like those can sometimes be the people that are hiding in the crevices. So that's my question.
The answer to that, from my perspective, is very straightforward. It's proactive outreach. And it is, so we actually, Jed and I, actually, we would present this data to corporations frequently. And the corporations would say, but what do we do? What do we do? And most of them, to be fair to them, were not big enough to have a Worksite health center. And so we actually started a program called My Personal Health Assistant, where literally they call the members. So the corporation sets them up saying, you have a personal health assistant, and you can do that through multiple, you don't have to use our company, you can use multiple different companies. And then and if they call you, they can save you money, they can make your life easier, they can help you find the resources. We're paying for all these benefits that people aren't using. They can put you in touch with ways to spend less money and make your life better and get better health. So then what happens is the PHAs reach out and say, hey, my name's Susan, and I am your personal health assistant. What would you like to achieve this year? What can we do? So forth. But it's a motivational interviewing, how do we serve you attitude. It's not a, you've got to do this. Now, ironically, when the corporation puts plan benefits in place, it says everybody needs to talk to their personal health assistant in the first quarter. The average person that talks to a PHA once will talk to them 6 times that year. And so sometimes it has to be a little strong arm to get them to engage, but once they do, it just takes off. So the key is that people in that right lower quadrant, if you walked up 30 seconds from having a heart attack and said, how do you feel? They'd say, I feel fine. And 30 seconds later, they're having a heart attack. So I feel fine and I'm healthy are not the same. People in the left lower quadrant, I feel fine means I'm healthy. The people in the right lower quadrant, I feel fine does not mean you're not at increased risk of having something happen. 70% of the time, if we can get that person to engage, it won't happen to them. So it is a matter of life and death. And that's what Jed and I have committed our lives to make happen.
Great.
And Allie,
Awesome.
to your point, and to pick up on what Scott said, the team at Cleveland Clinic Union Hospital, they have repurposed their patient navigators to be like the MyPHA folks that Scott was mentioning. And so the relationship that exists between the primary care community and the employer, in this case, Union Hospital, is delegated outreach to this team. So the team every month gets a list of the folks who are living in that right lower quadrant, who are both part of the primary care program and aren't part of the primary care program. So it is the care team that does the heavy lifting, not the human resource department.
Yeah, same thing up in the Queens, New York, is we give them the list for each of their clinics. They have 176,000 Medicaid and Medicare people. We give them the list and they just sort it by the risk. If it's rising risk, they focus on those first, or if they haven't been into the primary care doctor's office in a timely fashion, then they will also reach out to them. So it allows them to prioritize and integrate their Epic system with the health data.
Great, thank you very much. Francis Dakar, any question or comments?
Sure, this has been a great presentation, and we've been doing this for several years with different municipalities. With the town of Oro Valley is one of them, with zero claims, feeding the data through United Healthcare and working with their broker. But unfortunately, all brokers are not easy to work with, and the one I'm having a very hard time with right now is locked in with their InfoLock, because they say that it's all proprietary information. We've been feeding data to them for 3 years, and I don't get to see any of that information. So finally, my client is getting very involved, because even after our last meeting, Larry, that we were at, and we talked about data, they're self-funded. That's their data. And it's just super hard to get data or to get brokers to participate in some of these things. So we use, I'm sure you're aware of it, Springbuck and Darewalk, but with Invelock, with Locked-in, I don't know if any of you guys have any, if you're working with Invelock or Locked-in or anything, but have you guys had any success in getting anything from Invelock?
So I would say that, again, the CAA has basically said that the data belongs to the corporation, period.
Yep.
I do work with Lockton in a number of instances, and they have really wonderful physician executives on board that maybe you could talk to one of them directly. I've never been able to get them to share their data, but what we have done is we have the data lake. So we just get the insurance company to send the data straight to us, and then we give it straight to them. We do an end around when we get obstructionists who have a different agenda than adding years to the life and life to the years of the patients being served.
Well, I actually did speak with, this was recently 2 weeks ago. I spoke with their clinical nurse practitioner that they brought on for Invelock. And unfortunately, she has they haven't been feeding Invelock any of the biometric data. So the only thing she has is claims. So the only thing she's going by is medication claims or primary claims or specialist claims. And I had actually more data than her because we just completed their complete physical exam program. So we had all the numbers. And I don't know if any of you have ever heard of CIBA, CIBA, but my client wanted to throw some of the diabetics over to CIBA so they could try to get them, they call it in remission for diabetes. It's just been a nightmare. It's really been a nightmare, and we have all of our data. So I hear everybody's frustration because it is the employer's data.
Gotcha. All right, we need to continue on. We're going to continue past the hour if people want to stay on. So let me ask Jennifer Kester. Jennifer, any comments or questions that you have? Take yourself off mute, Jennifer. Yeah. Okay. Megan Cast. Megan, any comments or questions?
They control us.
Is that Larry Boers?
Go ahead.
I was just curious.
Okay.
Yeah, they're
Any comments?
controlling us. We can't.
Yeah, we can hear you if you want to talk. So if somebody have a question, Vice Stephen Hansen from Premise. Stephen, any comments or questions?
Yeah, just one question. I heard Scott mentioning how providers using Epic in one of the systems, they were able to access some of the compiled claims information, integrated and compiled claim information. So just wondering kind of best practice. I know that Epic has that capability probably better than any other EMR, but when you deal with other EMRs, how are you able to get that information in front of a provider and make it actionable?
Yeah. So Stephen, thank you for that. And I know you all have Epic, and it costs $1 million to do literally an API between a data repository and Epic, and you have to have a sponsor and things. So it can be quite challenging. But the good news is that, you can toddle, walk, jog, and run. And so we have been able to figure out how to do that with Epic in that example I gave, using CSV files and using the tools that are available from the EMRs to upload data and to make it visible to those. And you and I know each other from our many lives, so would love to chat with you. One of the things I think that Kimberly mentioned, she uses Cedargate now. It used to be Deerwalk, but we literally take a feed out of Cedargate and run our analytics against it and hand it off to the clinicians, and that can be done very efficiently.